I'm Dr. Shubhankar Godbole. I'm a consultant in gastroenterology and IBD. I'm trained in intestinal ultrasound. I work with Midas Hospital. So traditionally, we have been living in the land of infections, as we all know. Today, with industrialization and economic growth, India has seen a drastic shift in its lifestyle and the way we live. So there is an improvement in the hygiene and lifestyle changes with a resultant increase in the communicable diseases in general. I think the physicians would agree, and there is also a resultant increase in IBD. So why is it important to recognize the inflammatory bowel disease early? There has been meta-analysis which show us that, which have studied the impact of diagnostic delay in IBD. On an average in the developing world, diagnostic delay in Crohn's disease is almost 11 months, that is almost 1 year, and that of ulcerative colitis is almost 8 months. With the delay in diagnosis, there is an increased risk of stricturizing disease, penetrating disease, and surgical interventions in Crohn's, and the risk of colectomy in ulcerative colitis. We start with the cases. Here we have a young female who is a bank employee, presented to us with high-grade fever since past 5 days. She had significant abdominal pain which was mild periumbilical region, relieved after stools and associated with vomitings. CBC showed essentially normal CBC, TLC, hemoglobin and platelets. The routine fever workup, dengue, malaria and chikungunya were negative. Thereafter she developed loose stools with a frequency of 8 to 10 times every day, trace amount of mucus and blood with mild spasmodic pain relieved after passing stools. So we did a CT abdomen in order to evaluate her abdominal pain. Blood cultures and Vidal test was negative. So thickening, we found the thickening in ileocecal region and extending into ascending colon along with a few non-necrotic nodes. So, just animations are not running. Okay. So we come across a dilemma whether this is inflammatory bowel disease or infection. I would please request you all to take the voting pads in hand. Vote for A versus B. So yes, I think audience is correct. Infection is more likely. So we have a very important table here differentiating between inflammatory bowel disease and IBD. Any patient who presents to you with an insidious onset and history of more than 1 episodes of diarrhea in the past, there is essentially no fever or fever onset of more than 1 week after the disease. Vomitings are usually absent, and at the onset the bowel frequency is low, that is 3-4 times, 6 times every day, except with acute severe colitis of course. The presence of extraintestinal manifestation and perianal disease are some telltale signs of inflammatory bowel disease. Whereas in infective diarrheas we have an acute onset initial episode, fever at the onset of this illness is common, presence of vomitings and more than 8 to 10 episodes of bowels per day are common. We can find ancillary history like history of travel in infective diarrhea. So we did a colonoscopy for this patient in order to evaluate for ileocecal region thickening. We found irregular ulcers with significant erythema and edema around the ulcers. There were some superficial erosions or ulcers in the ascending colon as well. Biopsy showed moderate active inflammation. There was no chronicity and no granulomas, and the patient was improving after broad spectrum antibiotics. So colonoscopy is not a rule in acute diarrhea. It is rare thing to do. However, the patient had insisted us, so we did a colonoscopy for her. In this setting, viral enteritis is likely more common than bacterial enteritis with a negative blood culture and stool cultures and negative or equivocal Vidal. So coming to a second case, we have a middle-aged male who is a corporate employee presented to us with altered consistency of stool since past 6 to 7 months. Bowel frequency was constant for around 2 to 3 times every day. However, the stools were soft with a Bristol score of 5 and blood was not there. The patient had a significant complaint of inability to gain weight. However, there was no fever, cough or vomiting and the vitals were stable. His CBC was normal, LFT, RFT were normal, ultrasound was normal and TSH, anti-TTG both were negative. So what will be the next step in management of this patient? What would be the next investigation of choice? Sir? No. No. Pain. Yes, sir. Voting. A, sir. A, B, and C. Not able to make out. I think calprotectin, yes. I think that is the right way to do. So the red flag signs for inflammation or malabsorption are fever, night sweats, weight loss, inability to gain weight, which is in our patient, bloody stools, joint pain, or even nighttime symptoms. Nocturnal symptoms are very important. Reactive arthritis, diarrhea, which along with systemic signs and nutritional deficits. These are our red flag signs. And yes, we did the fecal calprotectin for this patient. As we know, calprotectin is a neutrophilic enzyme which is released during inflammation and is detected in the stools. Cutoff value of less than 50 microgram per gram of feces has been shown a sensitivity of around 85% and specificity of 91%. However, this test is better having negative predictive value. That means the absence of disease on finding normal levels is, okay. But positive, like elevated levels may not always indicate the disease. So our patient's fecal cal level was 280, which was elevated. Hence, we did a colonoscopy, which showed loss of vascular pattern, erosions, and ulceration. Biopsy showed moderate chronic inflammation suggestive of ulcerative colitis. So how would you initiate the therapy given that this was left-sided colitis? Whether we give him systemic steroid, 5-ASA, budesonide, or biologics. So yes, I think systemic steroid is not the right way to do here. Biologics, I think nobody has said. Maximum people are saying systemic steroid, but in this case, I would like to differ. 5-ASA is the way to go because this is a mild disease clinically and endoscopically. Initial line of treatment should be 5-ASA. Along with that, we can give him local therapies with enemas. So this is the flow chart of ulcerative colitis management. Here we can see in the moderate to severe disease. In the moderate to severe disease, topical 5-ASA or topical steroids are the way to go. In moderate to severe disease, we have to stratify the risk as low risk and high risk patients. High risk patients, we have to initially give a course of systemic steroid. In this case, 5-ASA, we started the patient on 5-ASA, that is misacol and folic acid. Clinically, the patient improved well, gained weight of 2 kg over the next 2 months. Stool frequency came down to 1 to 2 with an improvement in the stool consistency. However, we should note a point here that mesalamine response rate is only 40 to 70%. Almost 30 to 50% don't respond to mesalamines, and the remission rates are quite low, that is 15 to 20%. The patient did well for 2 months and then started having loose stools with trace amount of blood every day. There was no episode of fever or abdominal pain. So how do we manage the patient next? Do we give him systemic steroid, budesonide MMX, or add an immunomodulator? Yes, so there is a mixed opinion. This is a classic case of flare, that is relapse of the disease. The commonest causes including non-compliance of medication, NSAIDs or antibiotic therapy. There can be some intercurrent infection or some infections like C. difficile or CMV super infection. So in this patient, we started him on low dose steroid, which was budesonide MMX. So in flare, first we should check the proper history, sir. Our patient had an intercurrent episode of fever, and that is how we started the flare. So, how to induce remission in a case of a 5-ASA non-responder? We have to give systemic steroid or budesonide, small molecules or biologics can be given, and the maintenance of remission should be done by immunomodulators, biologics or small molecules. We should avoid long-term steroid use because of obvious long-term side effects. However, nowadays we have a very nice multimatrix system formulation of budesonide, which is released almost entirely in the large intestine and has a very high first pass metabolism, so less chances of long-term steroid side effects. We can, of course, give immunomodulators as a maintenance therapy. Azathioprine has been shown to have a significant benefit over 5-ASA in maintaining remission. There have been higher rates of success, that is almost 53% rates of maintenance of remission as compared to 5-ASA alone, which is almost 90%, 19%. Notable adverse effects of azathioprine are pancytopenia or neutropenia, which we have to be very careful with regular CBC monitoring. The patient can have pancreatitis or alopecia, which is one concerning complaint of the patients. As we know, so in ulcerative colitis, azathioprine and tacrolimus have been shown some role, but methotrexate is not effective. Next case, we have a 36-year-old school teacher who is a known case of ulcerative colitis on stable doses of 5-ASA, presenting to us with sudden episode of bloody diarrhea with eight episodes having blood in every stool. Her vitals were deranged, CBC showed a low hemoglobin level and CRP was elevated. Fecal calprotectin was highly elevated to 1800. And what is the next best step? So this is a case of acute severe ulcerative colitis in a known case of UC. IV systemic steroids is the way to go. True love width criteria we have seen in the previous lecture. The patient fits into severe acute colitis. We start the patient on routine blood workup, CBC, CRP, LFT, RFT, and electrolyte should be regularly checked. We should always rule out Clostridium difficile because in ulcerative colitis background, Clostridium difficile infection can occur even without antibiotic therapy because this is already a state of dysbiosis. We have to send for stool cultures in order to rule out any significant bowel infection, but we should not withhold IV steroids in awaiting the culture reports. We did an unprepared sigmoidoscopy which showed severe ulcerative colitis with a UCI score of 7/8. Initial line of management is IV steroids. On day 3, we have to assess the response to steroid. If not responding, we have to start the patient on advanced therapies. We have to always be aware of the complications. On the left side, we can see a picture of toxic megacolon, which is usually caused by C. difficile infection, electrolyte imbalances, or just severe acute colitis, and the patient should be given surgical options. We have to also be sure, we have to surely rule out perforations, which is a common occurrence. My time is 25 minutes. So is it possible to predict the steroid response? That is our question. And when do we think about early salvage therapy for these patients? So we have a criteria, what is known as Oxford Third Day Index, which has been studied in prospective 51 patients. It is quite old study done in 1996, but still holds true. If on the day 3 of admission, stool frequency stays more than 8 per day, or CRP levels are more than 45 along with stool frequency of 3 to 8 times per day, the patient is likely to undergo colectomy with a very high risk of 85%. Newer data is coming up from India. Here we have a study which was done in AIMS, published in 2017 in JCC, which tells us that ulcerative colitis UCEIS score of more than 6 on admission and fecal calprotectin of more than 1000 on day 3 have been shown to be independent predictors of steroid failure and the need of rescue therapy or colectomy. Now, what is rescue therapy? We usually had cyclosporin in the past. Now it's slowly being outdated and replaced gradually by infliximab, adalimumab, or the new kid in town, that is tofacitinib. We have strong data now showing tofacitinib efficacy in acute severe colitis in a dose of 10 mg thrice daily and later on switching to 10 mg twice daily after day 3. Biologics, as we know, are complex antibody structures, large molecules which are produced by living cells. Classification we are aware about. OMABs, ZIMABs, ZUMABs, and UMABs, which are gradually humanized. There are various targets of antibodies. The commonest ones are anti-TNF antibodies, which is infliximab, adalimumab, golimumab, and certolizumab, which are not very effective in UC, which are not very effective in IBD. We have interleukin 12-23 inhibitors nowadays, which are gaining traction, like ustekinumab. In India, we are shortly going to get mirikizumab and risankizumab maybe next year or so. Alpha 4 beta 7 integrin inhibitors, which are vedolizumab, which is available in India. So in India, vedolizumab, infliximab, adalimumab, and ustekinumab are currently available. Risankizumab and mirikizumab will shortly be available. Now, small molecules are, as the name suggests, they are small in size. They have clear-cut advantages over antibodies, that is biologics, lower molecular weight, faster absorption, more predictable action, and more predictable synthesis. Formulary is fixed and which is not variable like biologics. Multiple targets of small molecules are available, and most of them are currently under studies for ulcerative colitis and Crohn's disease. Commonly used are JAK inhibitors. We already have started the use of tofacitinib. Opadacitinib in Crohn's disease is coming, the trials are underway. S1P modulators, that is sphingosine 1-phosphate modulators. So S1P is basically a gradient which directs the movement of lymphocytes towards the inflammatory area. S1P modulators change this movement and reduce the inflammation. Maybe they are next game changers, maybe not. The time is still there. Tofacitinib has been shown efficacy by the Octave trial. There has been significant response as compared to placebo of 40%. However, in general, the antibodies, that is biologics and small molecules, have a response rate of somewhere in the range of 60 to 70%. Remaining 32% patients do not respond to small molecules or biologics. In them, there are newer molecules which are coming up. We have to be aware about thrombotic risks, major adverse cardiac events, herpes simplex reactivation, and tuberculosis reactivation while using tofacitinib. Next, we have a very interesting case. She is a 23-year-old female patient who was recently married, had an intermittent diarrhea since 1 year. 3 months ago, the patient had trivial trauma over the leg, followed by reddish swollen feet, which got ulcerated, and the patient underwent debridement, consulting a local surgeon. However, this debridement healing took a prolonged course. It took around 3 months in complete healing. And currently the patient presented to us with bloody diarrhea, which was 5 to 6 episodes per day. There was significant weight loss and pedal edema. Lab parameters showed hypoalbuminemia and low hemoglobin of 9. So, any guesses what this is? Whether it is... Yes, very rightly, sir. The patient was being treated as cellulitis of the leg because of trivial trauma. However, this turned out to be pyoderma gangrenosum. We have to be aware about the extraintestinal manifestations of Crohn's disease, which are more common in Crohn's disease than ulcerative colitis. Most commonly involved are joint, skin, eyes, and liver. And the notable point is that extraintestinal manifestations can present earlier than IBD in 25% of the cases. And this implicates the treatment plan. So here on the left pane we have erythema nodosum, here we have episcleritis. How do we manage extraintestinal manifestation? There are certain extraintestinal manifestations like pyoderma gangrenosum, episcleritis, and primary sclerosing cholangitis, which do not strictly follow the disease course. Rest of the EIMs closely mimic the disease activity, and hence we have to always treat the underlying disease by the use of, initially the use of systemic steroids. Nowadays tofacitinib has been shown to have a good role in EIM along with that IBD maintenance. In arthritis we can give sulfasalazines, and PSC, UDCA and liver transplantation remain viable options. Next we have a young male who presented to us with intermittent abdominal pain which was cramping type and was associated malaise. On leading questions, the patient complained of weakness, but this was more likely to be low-grade fever, which the boy was not able to tell. ESR was high, CBC-LFT was essentially normal, and chest X-ray was normal. For evaluation of pain, we did a colonoscopy, which showed us a bulky ulcerated IC valve, There were, as we can see, transverse ulcers throughout the ascending colon and cecum. Biopsies was showing granulomatous inflammation with caseating necrosis and Langerhans giant cells, which suggests ileocecal tuberculosis. The patient was started on ATT and improved within 2 months. Now, TB and Crohn's always remains a dilemma because of their overlapping signs and symptoms, poor sensitivity of the tests, and the fact that ITB is paucibacillary, thus difficult to culture. We have Lee's criteria, which gives us a differentiating between tuberculosis and Crohn's disease. There are certain points like longitudinal ulcers, aphthous ulcers, cobblestoning, or anorectal involvement, which favor Crohn's disease over over tuberculosis. And of course, we know that whenever we are in doubt, considering the high prevalence of tuberculosis in India, we should always start the patient on ATT, which is more likely empiric ATT, and assess the response after 2 to 3 months by repeating a colonoscopy. If the colonoscopy shows disease improvement, it is likely to be tubercular, and if the colonoscopy is showing no improvement or maybe stricturizing disease, it is more likely to be Crohn's disease. Next, we have a young male who presented to us with weight loss of 20 kg over the last 2 years, having intermittent symptoms of small bowel type diarrhea. There was one episode of doubtful SAIO 1 month ago. The patient was conservatively managed and got okay within 24 hours. So we don't know conclusively. CBC was showing low hemoglobin levels and B12 levels was low. On CT, we found a long segment stricture in long segment hyperenhancement in jejunum. We did what we call as enteroscopy. Enteroscopies are basically long scopes with overtube balloon used for visualization of small bowel. It has a clear advantage over capsule that simultaneous biopsies or interventions can be done. We can see here nice longitudinal ulcers and a circumferential stricture which we found in mid to distal jejunum. Biopsies showed chronic active inflammation, hence proven Crohn's disease. I would skip the voting. Best therapy in this case is not long-term steroid because the patient comes into high risk group because of his age and small bowel stricturizing disease. He is and for biologics. So we induce the patient with biologics and steroids and biologics, and maintain the patient on biologics along with immunomodulators. Dr. Raju has discussed the top-down approach and step-up approach previously. I would not go into detail. Managing Crohn's disease, in this case, the patient has extraintestinal manifestation. If the patient has perianal disease, stenotic disease, and the need of systemic steroid, we straightaway start with top-down approach. This is a table showing combination therapy better than monotherapy of infliximab, and an Indian experience in short of tuberculosis. The TB reactivation was found in 11% of the patients out of a total cases of 69 who were started on infliximab. So the rate of TB reactivation in India is generally on the lower side. However, we have to be thorough with the screening part. Ustekinumab is coming up in a great way, which has lesser activation of tuberculosis. So coming to the take-home points, we have the prevalence of IBD in India is increasing. It is important to detect IBD in its early stages and treat to achieve the given therapeutic targets. We have to stratify the patients in high risk versus low risk groups. Top-down approach to be used in high risk groups, that is hit hard and hit early therapy. Biologics are safe and effective and they also alter the natural history of the disease, so they have to be used extensively nowadays. Small molecules are emerging as new modalities in the IBD management, and they still have long way to go. Cost remains a major hindrance in the Indian scenario, which limits our use of biologics and small molecules. We are trying to find out biosimilars. Maybe in coming few years, more patients will be on biologics. Thank you.
So thank you so much. It was a very nice presentation. The cases, they covered all the various aspects of inflammatory bowel disease, and you have put down all the take-home messages very nicely. I just wanted to ask you that in Indian scenario, in our setup, usually we have patients who come to us for the first time with chronic diarrheas. Some may have blood, some may not have blood. So classical clinical features are not there. So in that setting, it becomes very difficult to distinguish between tuberculosis and inflammatory bowel disease. So do you have any comments on that?
So generally, intestinal tuberculosis has ileocecal involvement. Most of the patients they present, they have some history of low-grade fever or weight loss. Few of them do present with only diarrhea, but only diarrhea is less common as compared to abdominal pain. There can be 1 or 2 episodes of subacute bowel obstruction which have to be evaluated on CT. So CT enterography, I think, is the first and foremost modality in chronic diarrhea.
That's what I wanted to stress, that many a times before going in for colonoscopy, usually CT abdomen is done, and then again it shows some minor mesenteric lymph nodes are there, some bowel thickening is seen. So it becomes really very difficult to distinguish between tuberculosis and inflammatory bowel disease.
In a case of chronic diarrhea, who presents
Yeah.
to you with chronic
First
diarrhea,
time, coming for the first time.
yes, we should actually go ahead and do a CT enterography rather than
Yeah.
CECT.
Any other questions from the audience?
So very nice overview, Shubhankar. I had a quick question. So when you have patients long-term ulcerative colitis, for example, and then in which flares would you recommend evaluation with biopsy, CMV, C. diff? Would you recommend in every flare? Or in certain times you'd consider? Because that's a practical challenge we face, right? You have an IBD patient doing fine, now has a flare. Should we just try empiric steroids? Because biopsies, CMV becomes expensive for these patients. So what's your style? I guess there's no data probably, but what's your style? Yeah.
Whenever the patient presents to us with flare in a known case of ulcerative colitis, we usually follow the simple plan. We start the patient on steroids. We first take the history, whether the patient has any predisposing factors, whether he has had fever, any intercurrent infections, whether he has taken NSAIDs or any broad spectrum antibiotics, which are likely to cause dysbiosis resulting into the flare. Usually we find some history. If there is no clear-cut history, we start the patient on, if there is clear-cut history, we start the patient on steroid. If there is no clear-cut history of relapse, we take the patient for intestinal ultrasound or sigmoidoscopy, unprepared sigmoidoscopy. In unprepared sigmoidoscopy, if we find deep ulcers, it is better to evaluate for CMV. Now, CMV DNA is most likely positive in almost all the patients if we take samples. So, I am not very comfortable in starting the patient on ganciclovir or Valgan only on seeing high levels of CMV DNA on colonoscopic biopsy reports. But if the patient has systemic signs, if he has steroid resistant disease, we should think of CMV colitis.
Yeah. Oh, sorry, I thought I should also introduce Shubhankar, if not been introduced. Shubhankar joined Midas team, and he specializes in inflammatory bowel disease, and he's a fantastic addition to our team. And it's really good to have him on board because we can have great case discussions, and it's great to have you.
Thank you.
Yeah. Two comments which I would like to make is clinical practice, what happens, we see patients who are put on lifelong treatment, but the first thing which I asked the patient that what was your history? Many times it happens that very difficult to differentiate acute infective colitis, colonoscopy wise versus IBD. So if you have a history which is short before the patient underwent colonoscopy, you have to always find out whether this is ulcerative colitis. So that's one important message. Secondly, about the small molecules, I would like to commend upadacitinib, which is supposed to be a very quick acting within 24 to 48 hours and active in both an oral molecule. So it's active in ulcerative colitis as well as Crohn's disease. Another thing which is in the pipeline is risankizumab, which is again IL-23 blocker. So which is also supposed to be having a 10 to 20% high remission rate. And with the pharma going very strong, we possibly expect these molecules to be introduced next year or so. So that's but still overall, having all these armamentarium which we have, only 70% of the patients of IBD are treated and satisfied. 20 to 30% they still don't respond. But still, the surgical incidence is very less. Surgery is, people, they don't opt for surgery, at least in our setup. Thank you.
Thank you, sir. Sir, just a quick follow-up question on your comment. In your experience, Mukyar sir, sorry. In your vast experience, in how many patients have you started a treatment for IBD in their first presentation? Or you always wait and treat it as an infective episode?
See, if you have a history which is, say, more than 3 to 4 weeks, and you have a clinical, the colonoscopic presentations of ulcerative colitis, which is documented histologically by crib branching. You should have a crib branching. Crib branching would suggest chronic colitis. What are the signs of chronic colitis? Histologically, you should have either crib branching, you have Paneth cell metaplasia, or inflammatory cells which are in the form of plasma cells. If these are there, then it is chronic colitis. Crypt abscesses, cryptitis, polymorphs can also be there in acute colitis, similarly in infective diarrhea. So, you have to, all these things, you have to correlate history, colonoscopy, and the histology together. If you have a clear-cut 4 weeks, more than 4 weeks history, you are almost sure that this patient has ulcerative colitis. And one more comment, whenever there is an exacerbation of colitis in a patient with ulcerative, non-ulcerative colitis, it is more likely to be the exacerbation of colitis than an infective colitis, statistically. So you can go ahead with the relapse has to be treated like relapse of colitis rather than infection.
Thank you, sir. Thank you,
question?
Shubhankar. If you have a
Can
comment, we can stop this.
I think
You have a
if
comment?
you have a question for Shubhankar.
Yeah, sure, please.
So I think I won't ask you, I probably ask you the question which everybody asks. Crohn's versus TB remains a conundrum. Now, in your experience, how many patients have you had? I know you've had a lot of experience at AIG as well with a lot of patients. So what's your experience when you're having patients with this dilemma? What proportion of them have you seen turn out to be Crohn's, and what proportion of them TB? And what are telltale signs which make you feel one way or the other? Maybe a couple of comments on that.
Yes. So, as I had previously also shown, there is a Lee's criteria, which tells us that longitudinal ulcers, aphthous ulcers, involvement of ileum and colon, both, they are more pointing towards Crohn's disease. Transverse ulcers, shorter history, presence of only ileocecal stricture without any other ulcers, they are more likely towards tuberculosis. Now, we had analyzed the data of around 600 patients whom we had an initial diagnostic dilemma whether it is TB or Crohn's disease. The people who were started on anti-TB therapy, out of them almost 60% responded to the initial tubercular therapy. So we termed them as tuberculosis. But later on, these patients also started showing us symptoms. So it means that there is some entity in India which is secondary tuberculosis overlapping over Crohn's disease. And almost 20 to 25%, I'm not sure exactly, but those number of patients developed Crohn's disease also. So out of 600 patients, there were hardly 30% patients who were purely tuberculosis. And remaining 70% who were either purely Crohn's or TB over Crohn's.
Dr. Shubhankar, so my question is, first of all, congratulations for this very nice presentation. Patient with mild UC, with the left-sided, and patient is intolerant or not responding to the mesalamine therapy. Now you have started budesonide MMR. So for how many days you will continue this steroid?
2 months.
2 months. And after that, we have shift patient on the.
But he's not tolerating mesalamine.
Yeah, exactly.
So either I would overlap with immunomodulators or start him on tofacitinib.
Okay.
No, sir, we can directly stop. But generally, what we give is 1 to 2 months of daily therapy, 1 to 2 months of alternate day, and then stop. Not needed actually. We can directly stop.
Thank you, Dr. Shubhankar, for the excellent talk, and thank you, audience, for the discussion. We close the. Thank you.
Thank you.
Thank you, Dr. Shubhankar, for the excellent session.